Good afternoon, everyone, and welcome to today's webinar, hosted by the University of Bath Institute for Policy Research and the Department for Economics. Thank you for joining us online for the third installment of the series on health policy. My name is Christos Vasilakis, and I'm Chair of Management Science at the University of Bath School of Management. I also set up and direct the Center for Healthcare Innovation and Improvement. Today, I'm delighted to be joined by Professor Mieria Jofre-Bonet. Professor Jofre-Bonet is Head of Research and Vice President of the Office of Health Economics. Mieria joined the office in April 2019 and remains associated to the Department of Economics and the City Health Economics Center at City University of London, where she has been Professor in Economics and Deputy Head of the Department and the Director of the MSc in Health Economics and the MSc in Economic Evaluation in Healthcare for more than a decade. She has worked on a broad spectrum of health economic subjects, including lifestyle and health behavior decision-making, topics in industrial organization applied to the healthcare sector and pharmaceutical regulation, willingness to pay for health insurance schemes by the informal sector in low and middle income countries, environmental factors in children's health and well-being, adaptation to health states, and migration and adaptation. Today, Mieria joins us to discuss the fronts opened by COVID-19 and current health policy projects at the Office of Health Economics. The advent of the COVID-19 pandemic prompting a slight change in the research topics of the office. Partly this was caused by funding calls reacting quickly to the pressing urgency to analyze the impact of COVID-19 on the healthcare system and individuals. But also the private funders, for example, pharmaceutical companies, who had to understand the implications of COVID-19 on the portfolios. Rapid demand for pharmaceutical solutions to COVID-19 have questioned the incentives for research and development in life sciences. This talk will discuss some of the projects they have been working on these areas. And finally, some housekeeping before I hand over to Mieria. So there are just a couple of notes I would like to share with you all. First of all, please note that your cameras and microphone will remain switched off. If you have a question, please submit your question via the QA function. You should be able to find a QA button at the bottom of your screen of the Zoom window. We will aim to respond to our questions toward the end of today's session. Finally, let me tell you that the session is being recorded, so filming and photography is taking place. Subject to no technical difficulties, the session will be available online as a podcast and video at a later date. So thank you all for joining us, and I'll now kick off today's seminar by handing over to Mieria.
Hello, it's a pleasure to be participating in your series, so I'm honored that you invited me, and I'll try to make a good use of my time. First, we'll have to manage to share my screen, which I hope you can see at the moment. Is everything okay? Yeah. Okay, so as Christos has kindly explained, I'm going to try to summarize what we've been working this very strange year at the Office of Health Economics and how the COVID-19 has impacted the direction and the trends of our main activity. So we entitled this, I think maybe it's a bit ambitious, the title, but we'll see what we can do with it. So the motivation for this talk is, as Christos summarized, is that COVID-19 has altered the priorities and relative weight of the different research areas at the Office of Health Economics and in many other research centers. So as he also said, so I thought he had read my slides, some of the pressure came from the environment, obviously the urgent question on how to incentivize fast and effective therapies and vaccines in such short notice. What is the collateral damage of COVID-19 on top of the direct one? How to attenuate or mitigate the health inequalities created by the confinement and everything that the confinement meant. What is the mental health iceberg generated by these months going to hit? When is it going to hit us fully, and how is it going to hit us, and what do we do about it? That's probably one of the biggest questions. And unfortunately, we are not working so much on this, but it's something that we are trying to get funding for. And then prompted by demand, as Christos was saying, the available resources for research shifted completely and were steered towards the COVID-19 related subjects for many months. So we quickly adjusted our strategy. So what I'm going to do is a brief introduction of how our research activity is organized at the Office of Health Economics. Then I'll talk about how we shift our gears due to the COVID-19. I do want to discuss, and I will welcome comments on a map of urgent health economics, health policy areas. And I'll give you some examples of what we've been working on triggered by the pandemic, and then I'll conclude, if that's okay. So the introduction, let me move myself. The introduction is that the office, I don't know if you are familiar with it, but the Office of Health Economics was created in 1962, and it was in fact created by the pharmaceutical company, but as an independent arm. And there is always, it's been going on forever. How we are at the moment is that they give us a grant that's independent, but they also hire some consultancy from us. But we've become an independent research organization and charity, which relies on being independent in the line of research we do. So we can do consulting, but our research is independent. So our research per se has four primary themes. One is the economics of innovation, that's more related to life sciences, and it's more seeked by the pharmaceutical industry. And then policy organization and incentives in health systems, value, affordability, and decision making, and measuring and valuing outcomes. So I wanted to show you a bit the economics of the innovation. As I said, it relates more to the pharmaceutical industry and life sciences in general, and it deals a lot with regulation and competition of this sector, and how the design of the right regulation, which is in fact also ends up being health policy because it affects issues of health in the population, how regulating properly this industry can achieve efficiency and effectiveness and promote R&D, drive innovation in the priority areas that were, as you know, AMR and neglected tropical diseases and orphan diseases, but now is mainly COVID this year. Then trying to find innovative pricing and financing solutions to incentivize R&D, and not only incentivize production, but access to innovative treatments, alternative pathways of clinical development, and evidence generation. This means how to use real world data to try to design a better system to incentivize R&D, but also to provide access to medical innovation. And also, because this is more industrial organization, those of you that do economics may be familiar with the word, is how the industry is organized, and how, if there is a role for the market competition to promote investment in R&D and access. It's, sometimes it can be achieved, sometimes it cannot be achieved. So it's which role is market competition, does market competition play? The theme leader of this role is Miquel Verdut, and maybe some of you, I know some of you know him. And yeah, he's very active. This year he's been very busy, I can tell you, with Adrian Taus, and now we have Dimitrios Koroklis that was recently joined the Office of Health Economics. Then we have the policy organization incentives in health system. And here we look at the internal and external, or intrinsic and extrinsic factors that incentivize agents in the healthcare system to behave in certain ways and achieve certain outcomes. And so this theme, for obvious reasons also, has been very active this year. So first of all, we need measures of productivity for healthcare systems that are valid. And we have to be able to measure if the trade-offs between efficiency and effectiveness are sometimes, if one should trade off one for the other. Then what is the role of funding healthcare, and the role of public, private, charitable sectors in the funding? And the measurement and prevention and reduction of health inequalities and discriminatory access to health and also social care services. So this theme tries to understand better the quality, how to improve the healthcare system in general in many dimensions. One dimension that's very important, as you know, these days is the health inequality that's been generated by different issues of funding. Sorry, I wanted to remark that the theme leader is Margherita Neri. She's a senior economist. And I had put here a graph of trying to explain what's the trade-off between efficiency and effectiveness. Sometimes some intervention can be effective, but it doesn't mean it's efficient. It could be effective, but it's not the best or the state of the art in terms of costs or other factors. So it's effective but inefficient. Equally, you could have an efficient and effective. That's the optimal intervention. But you can have ineffective and inefficient, which we should avoid at all costs. But you could have ineffective and efficient is pursuing the wrong goals, but it is efficient. It's not producing what we want or at the low cost that is needed. So then we have the value, affordability, and decision making. This is another theme that is more it's more value for money, if you want to summarize it. The leader is Chris Sampson, that you also, many of you know. He's a principal economist. So this theme studies the opportunity cost of adopting new health interventions. Also innovative methods to estimate this cost effectiveness threshold. I don't know if some of you may know that there's been some controversy about how to estimate it, and there is the York group suggested one way of doing it, and there's been several counter offers from the Adrian Taus and Bernarda Zamora, and that's the opportunity cost of new. And the issue is how to calculate this also internationally, because the data is quite complicated to get. So it's very difficult to know how much health gain we can gain from an intervention in the low and middle income countries if the information is not there to calculate it. Then there's value in healthcare. It's the principles underpinning the inclusion and measurement of elements for value in health interventions that is not captured conventionally. And also what this theme does is gather evidence on the social preferences for or against these, the consideration of these different elements of value in health, capturing them for to assess the value of an intervention. Also, this theme is working on elements of patient or social value into decision making and improving approaches to the structured decision making, AAK, multi-criteria decision analysis. So they've been busy, but I suppose they'll be more busy starting now. But the focus of our research has been rather the other two. And finally, there's measuring and valuing outcomes. The theme leader was Patricia Cubimoya, that you may know too, but now it'll be David Mott. This theme is based on, as the name is very clear, it's grounded on the basis that any form of evaluation of any intervention or health technology needs a good measurement and valuation of the health outcomes, and which health outcomes are relevant, and what to capture the essence of the problem, how they can be measured with robustness and reliability and replicability, and how they can be summarized to reflect their value also to different groups. So that's this thing. Now that I explained all this, that's how it's organized, I'll go to the shifting gears due to COVID-19. First of all, I wanted to present a graph I made up about health economic research in the foreseeable future. You will see I try to also combine our themes with this in the graph. You will see that the economics of innovation, I thought, is having a lot of attention, and I know it's not health policy per se, as I explained, but it influences very much health policy. So I think it's very important to keep it in the talk today, because you'll see more when I go on that it's becoming very relevant for all the issues related to health policy. So economics of innovation typically, I have some, yeah, typically was dealing with well, antimicrobial resistance and what I was saying before, oncology drugs and personalized medicine, orphan drugs, and neglected diseases. But now with COVID, we have incorporated how to express the development of vaccines and tests. And then this has been entangled in the question of do push and pull mechanisms realistic? Are they realistic? How do they work? To understand, to make you understand, for those that are not familiar with these mechanisms, are the ones that push more basic research when, basic research in life sciences is a joint investment from public resources and also private. And this is pushing what is needed before the process of approval and commercialization comes. And pull would be more then there is the issue of making it accessible to the market. These are two different there are mechanisms that have been used in different phases of the development of medication, and it's been now very debated for the COVID-19, as Christos was saying, for the vaccine, how to, if the combination of these two mechanisms could help expedite the innovation. All this is translates into regulation and competition that sets the basis of how we regulate innovation, commercialization, licensing, and so on. So this is a very hot topic at the moment, for obvious reasons also. Then we had the healthcare systems. We were doing before resource allocation, primary versus secondary care, prevention versus treatment. Here it would be also screening, how to uptake of screening by vulnerable groups, payment systems and retention of staff, capacity issues. It's been expanded to also, we're doing things in social care, integration of care continuation, how to alleviate the healthcare system with a good social care system that can absorb those like the elderly and vulnerable population that can not live really by themselves, but they shouldn't be taking up beds in the NHS or other hospitals. And yeah, so that's this is what I think at the moment would have been the research in health economics and with the implication of health policy that was hotter in those areas. Then of course global health has been always there, and yeah, it's been always there. I was going to say it's more there now than before. Really, it's been there, and it has to be there, and it will continue to be there, because we have big problems on how to make accessible the medications and healthcare to low and even middle income countries, how to make this system sustainable in certain ways. Now we have the added problems of the environmental and health environment and the large healthcare systems. We added the problem of this huge pandemic, but an underlying problem that I think we haven't been paying enough attention, and we should, from those that have skills to contribute to this research, is the impact of climate change on health. and also the health of the migrants. Some migrants are economic, but many migrants nowadays in this in the in low and middle income countries are due to climate change. And so how do we deal with measuring, improving the health of due to this climate change problem? The migration has provoked the acceleration of urbanization that has a whole set of new health care system challenges. And finally, I was going to say a top a research topic now that is very candent is public health, because the problems we had of health inequality due to health inequality and the deaths of despair that Angus Deaton talked about 2 years ago when he gave the annual lecture at the Office of Health Economics. There's also the inequality that is being provoked by the fast digitalization of society, but in particular healthcare, and I'll talk more about this. And of course, the underlying iceberg I call the mental health that is probably the biggest health loss provoking factor in the world at the moment. So this was my map of very up-to-date research topics, and I was trying to think how COVID has affected this. I had these little things that I didn't put, but now I can put them. How this COVID affect this? So, well, it has put a lot of weight on the economics of innovation and the healthcare systems, but as a knock-on effect, it will put also in the next years a lot of weight on public health and how to deal with inequalities and probably global health. Here at the bottom, you see I put this, is it time to reform the WHO? Because this year has been very commented in some articles. The issue is that some people are saying why the WHO first has to become less bureaucratic and much more agile in the response and the capacity of be effective in situations like the pandemic we are facing this year, and also why if the pandemic is causing so many more deaths and economic loss than wars at the moment, why don't they have much bigger budget than the UN even? So I think this is something that is underlying the way we respond to problems like the pandemics or other calamities, and I'll keep it there in the map because we have to think about that. I'm very happy if you give me comments about this graph, and I would like to know your opinion about what are hot topics that are coming. Also, for sure, I left on the right-hand side that for all these, we need very strong research on measuring and valuing outcomes, because otherwise we don't know what's happening and how to make good decisions. And for that, we need how to measure the value, but also have a good strategy to decide when we go for something or not. So,
Mieria, you said you were happy for me to interrupt you at some point, given that you were talking to us about the overall portfolio of work within the Office of Health Economics.
Yeah.
Can you tell us a little bit more about the disciplinary background of the researchers, the economists within the Office of Health Economics? So, are you all economists? Do you all come from the same kind of area of economics? Do you bring in people with perhaps different expertise, like in public health or in antimicrobial resistance, or my expertise, which is operational research, perhaps a bit more closely related to economics? If you want to tell us a little bit about that.
Yes. Most people are economists, it's true, but the specialization, and I think there may be some people that are operation research also. So the specialization is very different, I think. Some people are more, sorry, now the phone is ringing. Sorry about that. Some people are more on quantitative econometrics, but there are fewer. Then there are people more specialized with valuing discrete choice experiments and so on. Should I let 1 second? I'll.
No, no problem. Actually,
No, okay.
You wanted me to put my phone on mute in case somebody's calling.
Yes,
Yeah.
this is the line, the landline. Then there are people that are more interested in healthcare systems and they have specialized in that healthcare system, and it requires quite a quantitative background too. And finally, there are people that are, I was trying to summarize our specialities, and then yeah, you'll see that there are many more people. There are some people on measurement and valuing outcomes, and it's discrete choice experiments, willingness to pay, etc., and others that never do that and are on another sort of silo doing more healthcare systems. And then we have the economics of innovation that come more from an IO and regulation and competition regulation and competition background. But there is not intransferable. Some people have transferred from one to the other, and we are trying to see if more of the junior can specialize in areas that we need them to, instead of what they came from. So in some ways there is some learning that goes, it's in the Office of Health Economics itself.
And in terms of size, how big? I mean, how many researchers? Ballpark figure. I'm looking for.
We are 26 at the moment. 26 economists. Yeah.
So you can undertake quite a few projects at any one point in time.
Yes, the issue is that because we are a charity, we are subsidizing the research with the profits from the consultancy side. So this gives, you have to keep doing consultancy at some rate, because otherwise you are short with research funding, you see.
We do the same with teaching at universities, but don't tell anyone.
That's true. That's true. Exactly. Okay, so yeah, any comment on the graph, or do you have any burning thoughts?
I have received a couple of questions, and also there are people interested to know about the background. Are these your economists, your analysts that are coming straight from academia? Have they spent time, or go back to different parts of the industry? If you can tell us a little bit about that.
Yeah, junior people usually come straight from a master. Then some people have from academia, but some have done and worked before they joined. But usually if they have experience, then go somehow faster than if they came directly after undergraduate. It depends on the person also. Some people have come, there are many people with PhDs at the middle and high level. So almost everybody has a PhD. But not everyone. And some have been working with a pharmaceutical company and then has joined. We don't have life sciences per se. We don't have chemists or biologists. It's all economics. But as I say, they can come from different areas of economics and different experiences before joining the office.
Thank you.
Okay. Okay. Should I move on?
Yes, please.
Okay. So I was going to say one of the first issues that have been a burning demand for to answer is the impact of the economic contracture on access to vaccines, because and this came from the private sector, in fact, because they were saying, well, they are saying that the demand for the COVID vaccine now will be very high. But the way that we've gone about, as I'll explain a bit later, it's been a bit different than usual. What does this mean for vaccines in the future? Because the economic situation is becoming so bad that there'll be no money later. That's basically the answer. So there was this talk that Graham Cookson, who is the director, and Lottie Stoyten, that is the health of consultancy. They did this talk. They were saying, well, the growth projections are very bad for this year. As you know, the world has shrunk by even -4%, 4.4 at the aggregate level. Some areas even more. The euro area has shrunk by 8.3, shrinking still. Hopefully we'll finish this year and then we'll say bye to 2020. And it'll be difficult, but is Latin American and the Caribbean is -8. Sub-Saharan Africa, luckily, has been less affected by COVID, and their economies too. But of course, they are at a different level, and well, but at least it's something good that they didn't experience falls of 8%. And then Middle East and Central Asia has fallen, but not as much as us or the Latin American and the Caribbean. And emerging and developing Asia, as you can see, they fell, but only 1.7. The point is that although this has been horrible, the good thing is that the provision for 2021 is that will grow quite fast, and even at a faster pace than we were growing in 2019. This is reliant on that the vaccines work, and hopefully this will be the case. So what's the issue? That to get us out from this huge pandemic and all the consequences, the governments have had to be very well, have to spend a lot of money on furloughs, subsidies, push mechanisms and pull mechanisms from the vaccine and treatments, healthcare deployment, healthcare system deployment, new hospitals, and so on. So the debt has increased a lot, which means, unfortunately, that we'll have to pay back this debt, and it's not looking so great for healthcare expenditure in the medium and long term. Although this was a healthcare issue, a health issue, a pandemic, this is not ensuring a bigger investment in health in the future, just because there will be not much money. So that was one talk that they gave, and so it's very important that we make the case that of the how health interventions, drugs and vaccines have a broader value that goes beyond just their value, because otherwise it could be that the investment in health expenditure and health research is even lower than we thought. So that's an issue that it's, I mean, there's some optimism, but there's also some gray clouds above us. But that was one talk. Then there's the Brave initiative that Lottie Stoyten and Eleanor Bell and Margherita Neri worked on. And this was trying to show, it's related to my latest point, the broader value of vaccines. And it's clear for a vaccine of COVID that is not only going to cure people having COVID, but that the value to society will be much bigger. And this is not only for COVID. COVID is a very obvious case for this, but it's what is obvious is that it's going to help us recover the economic activity, help us be able to socialize normally, maybe preventing a lot of mental health issues that if in the absence of the vaccine would just go monumentally big. And it will help become probably more productive if we don't get ill or are more affected by COVID because we have underlying comorbidities, and we can keep working or do what we do. So this project was just to point out that, for instance, a non-COVID vaccine nowadays, like the influenza vaccine or the pneumococcal disease, it's not only protecting people with COVID, but it's protecting COVID patients from other respiratory infections. So it's relieving the burden on healthcare systems, and this has itself an effect on, is a knock-on effect that compounds and magnifies the value, the direct value of the vaccine, even if it's not a COVID vaccine. That's another thing that we worked on this year. Then another issue that happened is that some grants that we had before, like this one on improving labor productivity in primary care, the role of skill mix, technology and patients, that was led by Graham Cookson, Patricia Cubimollà, Taneri and Bernarda Zamora Foundation, and it was looking at how would use English GP practice. Variations come from in organization and outcomes. What was the role of the skill mix and the patient population, and they wanted to also provide algorithms for routine measurements of productivity in primary care. But now with COVID, they have got an extension that's going to see what has determined the adequacy of the response of the primary care healthcare system to the shock that was imposed by COVID-19. So what makes some primary care units much more adjustable, who was prepared and why, what explains that some were more prepared and why, what is happening with these new ways of working, and has the population benefited equally or uniformly from these changes that the COVID-19 has brought. And yeah, and then relate again this with the original question that was, what is the skill mix and the technology, with these two factors, do they play a role in how much the practice has been able to innovate, adjust, and benefit the population? Yeah, and then of course this has the implicit issue of the digitalization, why and how this digitalization has worked for different pieces better than others, and for the population too. So that's an example of how COVID has changed a bit the purpose of one grant that we had. Then I don't know if some of you listened to this annual lecture that was given by Adrian Taus. It's based on a paper that he wrote with Isabel Firth. That's an example, and now that I think about this, Isabel Firth, she is more epidemiologist, and she came from the Wellcome Trust. She was working there, and now she's working with us. So that's an example that she's not a straight economist. So I'm happy to say that there's some diversity. So in this talk, if you heard it, it was a reflection on the scientific and commercial challenges that COVID-19 posed to the industry in terms of development timelines and certainty of anticipated demand, because when you are working towards developing a drug, you know what would be the demand more or less for this drug. It depends on the price at which you are selling it, but you know the population. In this case, the accelerated investment in vaccine production, development and production had a huge uncertainty in the demand that they could be selling to, and the financial risks they were incurring. So as you know, the governments innovated and got together with the pharmaceutical industry, in fact, in a collaborative way, in the sense that the government secured the demand, so they did advance purchases agreements with the companies that were investing in developing these grants. But at the same time, some of the companies have secured a certain price. As you know, AstraZeneca is going to sell it for the marginal cost. Others will have a smaller profit. So the nature of how we develop the medicines and vaccines has changed due to the pandemic. And then this paper reflects on, is this coming to stay? And there's another thing I'm going to talk about that is related to this, that by them too. And is this, how do we make sure that in a situation like this one, we can deal with it without totally disrupting the incentives in the long run to invest in R&D. And I'll explain better this. They suggest that we always make health technology assessment, make sure that the value is bigger than the cost of anything, because otherwise it will be at a loss. But also they suggest this procurement mechanism for low-income countries and these advanced market commitments based on the benefit, meaning you advance purchase, but you link it to the value that this is providing. If anybody is interested, the paper is available on our website, and it's dense, but it's a very interesting read because of the new issues that the pandemic has brought up. Related to this, I don't have to be much longer, is that, is the COVID-19 has created an exceptionalism in the business model of the life sciences, and is this coming to stay, or what do we do with this? So Adrian and et al. Argue that it has been a huge relief that the government and the industry got together and collaborated, and that they found new ways to push this forward at such a speed, because it has been a monumental response in terms of speed and effectiveness and for the vaccines. But this partly reflects the non-preparedness of the society and the international community for a non-flu pandemic. So the improvisation has undertaken all these changes, but one should make sure that whatever model is put forward still provides not only short-term rewards to those working on a vaccine or a medication, but also in the long run. And for the long run, working at marginal cost or a very low profit is not sustainable for the companies. So this is an ongoing conversation that has to be had. It's not confusing short-term incentives and short-term solutions for the ones that work in the long run, where you have to have an incentive to invest in uncertain things in the future. Other things. We were asked also by the European Parliament group called Renew Europe to explain the key factors on how to procure, pay, distribute, and use COVID vaccines. It was very interesting because we learned about all the chronology of the vaccines and the R&D, and what is the portfolio, and how important it's to optimize the portfolio in terms of the different efficacy and effectiveness of the different effectiveness we don't know yet, because they have to be rolled out in the population, but the efficacy thresholds, how to link the advanced purchase agreements with the companies to the value of their vaccines, and how to make sure that the distribution priorities make sense and secure access to the populations that need it first. And finally, we were reflecting on this, how important it will be, or it is already, to educate and positively sensitize, for instance, young population about the benefits of getting vaccinated, because there is a lot of backslash on, and because the vaccine has been developed so quickly, not to get vaccinated. We can talk about this later, but we were reflecting on these issues. We also had, sorry, I'm exceeding my time, but I'm almost done. We had a very interesting research piece on the digitalization of healthcare during COVID-19, the considerations and the long-term consequences. And well, it was evident, this was done actually before the summer. It was evident that the fast digitalization of the primary care in particular was affecting differently different groups. Obviously, the elderly, so that the digital inequality was leading to health inequality, because they were less able to use the new systems of communicating with a healthcare provider. So this is a piece that's also on our website. And also they ask us to write this editorial about how to mitigate the negative effect of digitalization in healthcare and harness the positives. At the same time, we've been applying for grants, diabetes adherence during the confinement and long-term effects with some people at Oxford, how to increase screening uptake for cancer in low response groups and vis-a-vis COVID. Yeah, this was related to this blog, the effect of this digitalization. We are partnered with a primary care network in Camden, and also in global health with Bernarda and Gayatri. We've written a grant on the vulnerability index of Pakistan with the Population Council in Pakistan, trying to see assess the preparedness not only of the healthcare system but of the society in vis-a-vis a pandemic and other calamities. So I'm reaching the end. So I can say that the COVID-19 has indeed impacted our research and how we do it. That's why I put this picture of us all working remotely. We are not expected to go back until April or even September to our offices. We are really working from home. As I summarized, we've been working. The COVID pandemic has put a lot of stress on the economic of innovation research team and about how to incentivize quick development of vaccines and treatment and how to guarantee access, but also on the impact of COVID-19 on health systems and on health inequalities, how to measure appropriately and how to maximize the health with limited resources in this context. The preparedness of health systems, the preparedness of the health systems to face pandemics and other calamities. And a very hot topic is how to guarantee, as I was saying before, access to medicines and vaccines to the low and middle income countries, while we still promote R&D, new treatments and vaccines properly. So there is an incentive from researchers to do so. And that was it for me.
Thank you very much, Mieria, for this. We have about 10 minutes left for some questions. So you mentioned at some point, and actually towards the end of your talk as well, when you talked about the digitization of healthcare, at some point you talked about the extension to one of the projects around labor productivity in primary care. And we know from personal and perhaps some anecdotal evidence that telehealth has now suddenly become a much bigger deal than it used to be because of all the issues that we had and all kind of the fears that the system had and people within the system had in terms of expanding the use of telehealth. Do you have any early preliminary results to share with us in terms of kind of the impact that telehealth has had in primary care here in the UK or elsewhere in the world?
No, we don't have data yet. That's what we are trying to get. So it's what we have is evidence from talking to the primary network, primary network of care in Camden, of to which extent this was overnight, and how they have to be. That's why we were pairing with this with them to do this study. But that's precisely what we need: data before and after, and see what has been not only the penetration of digitalization, but also the impact on outcomes. We don't. That's what we want to be working on. So it's rather a working project.
Because of course, the fear is that increasing telehealth in primary care and other walks of health and social care will actually might potentially lead to an increase in inequalities, both in terms of access, but also in terms of other metrics. Have you come across any of these issues? I mean, the stakeholders that you've talked to is this something that primary care networks are addressing here in the UK at least?
Yes, they are trying to address it. I mean, from patient experience, they primary care, well, at least the one in Camden, is very much in touch with patient groups and it is evident that some population like the elderly and some people that are not able to interact by digital means have lost in this process. So they are trying. This project that we have together was trying to address precisely how to overcome this negative effect, because it's not only that they cannot access, that they are getting behind and more behind because this is here to stay. The digitalization, I don't think we'll go back to what we had before. There'll be a lot of screening through phone calls and video before they let you go.
A lot of people think that the genie is out of the bottle now, and it will be very difficult to put it back in again. Perhaps for the better, but also it's something that we need to be very mindful of, increasing inequality of access, increasing kind of the problems that we already had and we're facing. Telehealth has the potential to overcome them, but also has the potential of making them worse. So that's why I was thinking about it. So I have one question here from the audience. It says, what challenges you face in conducting research given the pandemic situation? Has the funding to conduct research increased, decreased in this pandemic?
Okay, the challenges, I think this is not only at the office, it must be in all research centers, but what we found is that we ended working more from home, and it's more that you are you are always in the workplace, which is a problem. But the challenge is that there are things like brainstorming that it's very difficult. It's more difficult to do through a video. There are issues like, for instance, some of the platforms don't even let you interrupt each other because you don't hear either of the speakers. So that creates a bit of sluggishness in the discussions. I don't know if you know. So the research activity has been higher, I would say, than it was. But the quality of the interaction with others, I think, has been affected, which means although we keep doing a lot of research, it's a bit more lonely, and I don't think that that is good for productivity. We miss meeting sometimes meeting and discussing and brainstorming. But no, I mean, in terms of quantity, it hasn't decreased. No.
It's something that we all face, in our collaborative research projects. I mean, it's easier perhaps to get together and talk, but then when it goes down to the detail and the nitty-gritty of the work, I find it more difficult to and the lack of a whiteboard or a blackboard where everybody can write something is a bit of an issue, and electronic versions don't seem to work really well. And in terms of funding, because the question will also have this kind of funding element to it. Has funding for your research increased or decreased during this pandemic?
Okay, I'll say in this case, I don't know if it was clear from the talk, we've had a lot of private funding from life sciences, life sciences and associations of life sciences that want to know how they address the new situation. And then public funding has been expanded, but there's a lot of competition for the same subjects, as you may have noticed too.
Yes, I have.
Yeah. So I would say that a lot of thinking has been funneled to the same subjects, and there's more competition to get the grants. But that's my impression.
Another question is around the cost effectiveness and more general the evaluation of vaccines or other interventions to combat COVID. And work, and I think it's also common sense to a great extent, has shown how important it is to evaluate the wider non-health benefits of vaccination, which you alluded to very, very clearly in your slides. Is it something that you have started tackling with through your research projects within the Office of Health Economics?
Say again, I didn't.
Including wider non-health benefits in the evaluation of either COVID vaccines or other treatments and other kind of interventions to combat COVID.
Yeah, I think COVID-19, as you say, has put a lot of stress on how important sometimes what are the indirect effects and positive externalities we call it of that one single medication or one single vaccine can have. So it's clear that the broader value of any intervention, it doesn't have to be a vaccine or an intervention. I think also public health interventions or primary care interventions, social care interventions sometimes are much bigger than, the effect is much bigger than what you design them for. And yes, there is quite a bit of research going on at the moment on the broader value of vaccines, of health interventions, and other aspects of health treatments. Yeah.
Thank you, Mariana. If I may ask you a final question that I have here, which is my question actually. It's how do you close the loop, as it were, in the projects that you undertake within the Office of Health Economics? How do you, what is for you usually, typically the end point of a project? How do you disseminate and how do you implement some sort of outreach activities for your research projects? Yeah. I can understand that different projects will have different audiences, but if you can give us some sort of
well, we make,
this
is a very good point. We make, well, because I came from academics like you, from the academy, I'm very positively surprised that one of the extra value that the office offers in this context is the dissemination via workshops, roundtables, blogs. So the outlets to disseminate are much bigger. One thing that is missing and we are investing in, and that's why I was admiring the social media skills of Eleonora, is how to go beyond on the social media and create threads that allow people to be more aware of all your research going on. But so it's very important to reach the stakeholders, and that's maybe sometimes academics we don't do it so much, and I'm learning now. It's go and talk to the patients, organizations, go and talk to the hospital managers, go and talk to the stakeholders that are involved, put them together, hear them, and give them back the outcome of your research. And this is something that we really put a lot of stress on.
Is peer review publication one of the outcomes, or you
yes,
don't?
you have peer review publications. Like this year we had 17 in 2020, which is a good number. But also publications on the website of the office. There is one type that is peer-reviewed, the Office of Health Economics peer-reviewed publications, and then there are the consultancy reports that are not peer-reviewed, well, minimally, and they are really what they wanted. But yeah, we distinguish our own publications online from peer review. Yeah.
Excellent.
Very good.
I think we only have a few seconds before the clock strikes 4 o'clock. So I'm going to thank you, Mieria, here for such a brilliant presentation, and to all of you at home or anywhere else for joining us today. Yes. Thank you also to Dr. Eleonora Fiquera, who has put together today's session and the whole health policy webinar series, actually.
Thank you.
As mentioned, today's webinar will be available as a podcast and online videos, and as an online video shortly. And you can also find recordings of previous events of the series online. Thank you again, and we hope you can join us again soon. Thank you, Mieria.
Thank you very much for inviting me. It was a pleasure.
You're very welcome.
Thank you very much.
Bye, everyone.
Bye.